Welcome back, class. We're going to jump into kind of the second segment or the second session, or let's just call this the bottom half. Call it the bottom half of the CMS 1500 claim form. And again, if you go to that NUCC document, pull it up, look at it, that bottom half is referred to as physician or supplier information. One thing I do want to kind of backtrack a little. When I spoke about, COB, coordination of benefits, and I was talking about employment, talking about auto accident or other accident, there are opportunities where a health plan or a vendor can go out and go to a state type of automobile accident database, and most states have them, and you can go in there and search for information talking about automobile accidents. And that's one reason that if you look at that form, and if you look at 10B on the form where it talked about an auto accident, if you say yes, it gives you an opportunity to say place. And that's when you put the state in there, then they can go back to that state database and start tracking down information that applies to that automobile accident. Same thing with employment if it's workers' comp. There are workers' comp databases out there that either the health plans can go out and try to extract information from, or vendors can hire vendors to go out and extract information from it too. So there are databases that can provide that information. And when I managed the payment integrity team in Buffalo for Blue Cross Blue Shield, one place that we found a surprising amount of information when it came to coordination of benefits, where would you think we found some of the most valuable information? Facebook. You would be surprised the number of individuals that are in an automobile accident, and they go into provider's office and they say, nope, wasn't involved in an auto, so sore necks, shoulders, chest hurts, nope, no automobile accident. And yet you would get out and you would track these characters down and on Facebook, and they would have pictures of their car where they wrecked it, and talking about how they hurt their neck and their shoulders. And one thing we developed at Blue Cross Blue Shield was a database that combined diagnosis codes and body parts. So if we had individuals that the claim appeared to be like a shoulder injury or a leg injury or chest injury or neck injury, we would flag that, pull those claims out, and analyze them just to make sure. And when I say analyze them, we were calling the doctor's office just to double check to make sure that the doctor's office, when they billed the claim, hadn't billed it in error. We were going out to Facebook and looking at that information for those individuals. And you'd be, I was always amazed at the number of people, information that they would put on Facebook. Also, workers' comp. The number of individuals that even work for the company that would file a workers' comp claim, and you'd go out on Facebook, they were out raking leaves, and they were up on the roof cleaning out the gutters. I mean, just the amount of information that you can get through public access or social media. So it goes back to just be really careful what you publicize on social media. And with that said, we're going to jump down into now, cell or box number 14. And that first thing it asks you, now we're starting to get into kind of the clinical reason or clinical rationale as why you show up to the visit. And 14 talks about the dates that that the particular incident happened, or that the particular day that you went to the doctor's office, a particular day you had the surgery, a particular day you were admitted at the hospital. And you have information down here, the name of the referring physician or other source. And there's two boxes, so that's in 17, box 17A and 17B. They give you the opportunity. Some providers on the claim, you have to provide your national provider number, NPI. Every healthcare provider has one. It is unique to that individual provider. It needs to be on the claim. And that's what you have in 17B. Now in 17A, and it's a different shade, that is an opportunity for providers to put information in. It could be they could put their state license number. Some will put their commercial provider number, because even though a provider is in a commercial health plans network, they're going to have an NPI that's a national provider identifier, and the health plan is going to give them a health plan number also. So sometimes that health plan number will show up in 17A. And then as you kind of move from, I'm moving from left to right here, as you move to the right side, there's box 16. And this is an somewhat interesting box, but it's dates patient unable to work in current occupation. So, and if you tie 16 to box 18 will give you the dates that the patient was hospitalized. So typically when you're in the hospital, you're not going to be able to work that first day you're admitted to the hospital, and you may not be able to work for several days after you're discharged. And that is information that health plans are going to use to try to determine if there are issues, again, going back to workers' comp, MBA, coordination of benefits. They will also try to tie information in 14, which is the date that happened to go to the physician is submitting this claim, with any dates in box 18. So physician may see you before you go to the hospital. Physician may see you in the hospital, especially if it's a surgeon. Surgeon's going to be there. You're going to be, if you're coming through the emergency room, so you're going to hit the emergency room, you're going to be admitted to the hospital, and if it's a surgical procedure, you may have the surgery done as soon as you're admitted to the hospital, or you may have the surgery done in between the emergency room and being admitted to the hospital. If it's elective surgery, you're going to be admitted to the hospital, and sometime while you're in the hospital for that hospital stay, you're going to have the surgery done. And so at that point, you've got a member, or again, a contract, depending on how your supervisor wants the information pulled, but you're going to have a member or a contract generating a multitude of CMS 1500s and at least one UB04. And so it'll be up to the analyst, the health informatics professional, to start pulling all that information together. And some of that information that gives you a starting point can come from box 14, can also come from box 18. Box 14 is an original date on the 1500, but it can also show up as on box 18 on the hospitalization dates. To go back to box 16, dates that you can't work. The payment integrity team that I managed or directed at Blue Cross Blue Shield, we would spend quite a bit of time investigating the employees that worked at Blue Cross Blue Shield that were out on workers' comp. Wanted to know, were they truly out on workers' comp? And so you were going back to the doctors, you were going back to the claims information extracted off of this CMS 1500, stored in the information warehouse, and you were you knew the patient's name, you knew, date of birth and that information, and you could go back and search through the claims data to try to pinpoint, were the dates provided in box 16, were they did they match up with the dates that the individual had told us that they needed to be out on workers' compensation. So a lot of again, valuable information here on this first few boxes on this CMS 1500 that you're going to have to utilize, or going to have to be able to understand how to extract from a data warehouse or some type of repository if you decide to go down that road of being a health informatics professional. It's also going to be information coming off of this 1500 that's going to show up on your explanation of benefits. And if you understand the information on the 1500, or the information that's stored or generated or populates the UB04, it's going to give you a better idea and a better opportunity to understand what that information is on the explanation of benefits. It's either mailed to you by your health plan, or you go into your health plan, you go through the internet or virtually into your health plan, you open up your account, and you can see all of your EOBs in there, and you'll be able to decipher that information, and you understand it's going to be coming from information that populates the 1500 or populates EOB. And so we've gone down through, we're to 18, 19, it's not typically used. Box 20, where it talks about an outside lab. If I go into my primary care doc in Atlanta, they have a lab in their office. It's a multi doctor practice, and they've got, I think there's 6 or 8 doctors in there, and they have a Quest lab in the office. Not all doctors' offices have those Quest labs. And so if you go to your doctor and that doctor says, I need a CBC, which is a blood draw, I need a urinalysis, I need a cholesterol screening, I need on lab work, they will write you the scripts, and you may have to take it to an outside lab, a Quest or some other outside lab. And that's where that information is going to show up in box 20. Also, if you may need, especially if you go to see a dermatologist, let's say you go to see a dermatologist and you've got some skin lesions. So you go to see a dermatologist with some skin lesions, and they may take and dissect one of those skin lesions, or they may take and have to excise it or cut out a skin lesion, and they'll want to send that to an outside lab to make sure it's not cancerous. They want to send it to ensure it's benign, so you don't have to worry about skin cancer. Skin cancer is huge in some parts of the country: Southern California, Arizona, Florida, even here in the kind of Louisiana, Texas, kind of along this sun belt in the south here. Skin cancer can be a huge issue. So don't be surprised if they've taken and actually excised some skin tissue and sent it to an outside lab. If you get down to let me see, I'm going to skip 21 right now, but if you get to box 22, talk about a resubmission code. So if you're a provider's office and you send in a claim and you're missing some information, the claim's going to be bounced back to you because it's not a clean claim. It's not going to process through the system. Or if one of my team at Payment Integrity finds out that you're fraudulently billing for services, and they reach out and touch you and tell you, you've got a choice. You can either resubmit the claim accurately, or we may be talking to the FBI task force and about a criminal investigation into fraud, you can, as a provider, you can take that claim and clean it up and resubmit it. So that's what it's talking about, resubmission codes. And box 22, you're supposed to put the resubmission code in. And if you've got an original reference number, you want to make sure you fill that in there too. And then box 23, it's prior authorization number. If the services that you are seeking, that you need to consume, kind of odd talking about healthcare, consuming healthcare goods and services, but essentially that's what you're doing. If you have some services that you're trying to seek and the health plan has a prior authorization mandate for those particular services, you will end up with a prior authorization number that the billing department at the provider's office will put into that box 23. And providers will get those because without that prior authorization number, they know they're not going to get paid. If we go back and kind of backtrack a little over to the left-hand side, there's where you've got box 21, and that's where you're going to start putting in your diagnosis code. Remember, we talked about diagnosis codes in the last module, and that's where you're going to start seeing these diagnosis codes pop up on this CMS 1500. And it's extremely important because the format of the diagnosis codes change from ICD-9 codes for that revision to ICD-10. And if you look at box 21, over kind of in the upper right-hand corner of that box, there's a little area there that says ICD indicator. And at that point, you should either fill it in as 9 if it's ICD version 9, or a 0 if it's ICD version 10. So just make sure that you understand that that's what we're talking about when we're talking about ICD-9 or ICD-10 codes. And then if you get down to box 24, this is where you're going to start looking at dates of service. And depending on the billing cycle, let's just say this is a physician's claim for office visits. Depending on the billing cycle, you could have multiple dates of service on a given claim. Some providers bill weekly, some bill bi-weekly, some bill monthly. And so if it's weekly, they leave the opportunity for, on these CMS 1500, there's room for 6 lines of service. So you may have to, if you're more than 6 lines of service as a physician, you may have to submit a couple of claims together to get them all on there. But you talk about the date of service, and it says from and to. If I go into my, see, today is the 12th. If I go into my doctor's office tomorrow, and it's for an office visit, my physician is going to put from and to dates. They're going to put February the 13th, 2024. They may bill me for a 99213, which is a medium level office visit. They may bill me for some lab work because, again, what we talked the last time, lab work is the 80,000 range of CPT codes. So the 99213 is an evaluation and management code, which I discussed last time. It's going to be on there. There's going to be maybe an 80,000 or maybe a multiple 80,000 codes, depending on what kind of lab work they did. If I sprain my ankle, and they have a little radiology center there, if I sprain my ankle and they want to make sure it's not broken, there may be a 70,000, series CPT code on there. If I go in and, then I've been out in the sun, and we'll go back to the skin lesions, and they may be going to excise, take off a couple of skin lesions. They may remove them. And if they do, there's going to be some surgical procedure codes on here. So it's going to be in that, 11, I guess it's probably a skin lesion is going to start out 11,000 502 or something. I don't know, but that'd be a skin lesion. And so you're going to start seeing dates of service pop in, and that's 24A. 24B is place of service. And I've been in the business long enough to know that place of service, 11 is an office visit. Urgent care is 20. A hospital's visit is 21. If it's an emergency room, it's 23. Those are just some that I just know off the top of my head. But in that NUCC document, you're going to find a link that will take you to an entire list of place of service codes, and there's several of them that you work with. That's what place of service goes in there. Column B, if it was an emergency visit, you would fill that in either Y for yes or N for no. If I'm going into my primary care doc's office, it's going to be probably populated with a no. I'm just coming in to see him. Either I don't feel well, I've got a sprained ankle, I need some skin lesions taken off, whatever you're in there for. Then you're going to, and not only in 24D are you going to put the CPT and HCPC codes in one column, but you've got 1, 2, 3, you've got 4 cells available to put in modifiers. Remember, we talked last time about modifiers and how they're associated with CPT code and HCPC code. And if you go back to that, let's say the radiology, so if I have, if they take a picture of my ankle and you're going to have a 70,000 code, and you're going to have a modifier TC for the technical component. There will also be a radiologist that will send in a bill to the health plan, and it's going to have that 70,000 CPT code for the radiology code. And that radiologist, because he or she read the film, we're going to put a modifier 26 on there. And so that's how the forms, again, we talked about CPT codes, HCPC codes, modifiers, they have to mesh and they have to make sense or the claim won't be paid accurately. But that's the combination that you're going to find that populates this CMS 1500. And then you're going to get into a diagnosis pointer. I think if I remember correctly, those are letters like A through L, and they point back to the diagnosis codes that you see up here in 21. So that's a diagnosis pointer to each of these lines of services and each of these lines of CPT codes and HCPC codes. Charges, that's going to be the bill charges. Days or units in column G, it's going to be the number of units. 99213, be one of them. I only went to see him one time. There'll be 1 unit for the x-ray. The laboratory information or the laboratory request will all be broken out with each individual 80,000 code, so there should be only 1 unit of those. And I think most in column H, most of that information is not really filled out. Then in column I, you've got the ID qualifier, and again, there's 2 lines on there. There's a pink shaded line, and then there's a blank white line that's got NPI in it. So on the line that's got the NPI indicator in it, because in column J, you need the rendering provider ID. And so the rendering provider is going to put his or her information in there by the NPI number. And the rendering provider can also fill in if they've got a number. The health plan may request that the provider put in the health plan designated contract ID number for them. So that's how we're pulling all of this information together. And when you get down to 25, you're going to get the provider's federal tax ID number. Could be an EIN, could be a social security number. The health plan's not going to really be that concerned as long as both pieces of information as long as both pieces of information are in their quote provider file. Again, in health plans, and I can't remember whether I went through it or not the last session, but in the last module, health plans generally generate three main types of files that feed into an information warehouse. You've got a claims file, which is going to grab information off of this CMS-1500 or the UB04. You've got a membership file that's going to grab all of the information that the insured individual has provided to the health plan. On the insured, they've got a spouse, they've got children. That insured has provided all of that information in a member file. And then you've got a provider file. And that provider file is going to have information, name, address, provider specialty, any types of subspecialties. It's going to have information where they went to school, where they did their residency, where they did their internship. You're also going to see the Social Security number. You're going to see the EIN. And again, that's going to drive the IRS or the W-2 or the 1099, depending on how the forms go out to the providers. And it's also going to have in that system somewhere that National Provider Identifier, that NPI number. Cell or box 26 is a patient account number. Most health plans don't capture that information. 27, it's do they accept assignment? And that's a yes or no. And if you're a network provider, like my primary care doc is for Aetna, he has to check yes. He is accepting assignment. If you become a member of a provider network, you have to accept assignment. And by accepting assignment, that provider has agreed that they will accept the reimbursement levels for all of the work they did that they've negotiated with the health plan, and not turn around and try to balance bill me, the member. There will be the total charge in 28, and 29 is going to be the amount paid. And typically that amount paid, for me, it's $10 copay. Or if you're on a deductible amount, you may have to pay your deductible. If you're on a co-insurance, let's say you're on your contract with your employer group has negotiated a co-insurance contract with the health plan, you may be on the hook for 20% of the bill charges. Number 30 is it's one that's not used. Let's see, what else do we have here? 31 is the signature of the physician or supplier, including degrees, credentials. 32 is the service facility location information. And 33 is the billing provider information and phone number. One thing that to remember here is, so the doctor in 31 signs it, dates it, and a lot of these, because the doctors aren't signing these, it's going to be SOF, signature on file. So it'll be, and it's going to be, a lot of these claim forms, they're all electronically generated. They're grabbing information out of that electronic health record. They're plopping this stuff in. It's electronically generated. And so it's just going to have SOF, signature on file, and a date. The service facility location is important because let's say that you are a pediatrician and you've got, you work 5 days a week. One of those days you work in an office in Nashville. One day you work in an office in Hendersonville. One day you work in an office location at Brentwood. And the other 2 days you work at Children's Hospital. You have an office in Children's Hospital. So location, service location is important because you've got Brentwood, Hendersonville, Nashville, Children's Hospital. You've got 4 unique locations. You could actually have 4 unique contracted rates, one contract rate for each location. So that's why you're going to have to make sure that 32, that service facility location is important. And then on 33, they're asking for the billing provider information and phone number. And that's where you're going to put in the, in the information that you're generating on the claim. So this is the way that you take and information is populated. Again, you got the top half, more demographic information, coordination of benefits, health insurer information. Then down at the bottom, you're getting into the clinical aspect and I can't even say the reimbursement aspect because it doesn't give you any reimbursement dollars. It gives you bill dollars. Here is the bill dollars that the provider and providers all, whoa, had a brownout. These are, lost my train of thought. The billing information, and every provider, whether it's hospital, multi-specialty practice, they all have a charge master. Charge amounts, billable amounts for all of these CPT codes, HCPCS codes, and the hospital based on revenue codes. I mean, there are a multitude of billed dollar values that match up with all of these different codes. Typically, they don't match up with diagnosis codes, but they do typically match up with CPT code, HCPCS code, revenue codes, that type of information. And so charge masters are going to feed directly in to this on that. See, I get the right number. It's going to be 24F. It's going to directly feed into 24F, and that is the unit. That is the number of charges based on the number of units. Charge masters change. Some providers update their charge masters on a quarterly basis. Some update them, on a annual basis. Just all depends on which the provider, what their process is on the charge master. And with that, we're going to kind of wrap things up. I would like to leave you with one thing to always remember is there can be, for any episode of care, there can be multiple CMS-1500s assigned to that individual for that episode of care. Again, could something come from radiologists, pathologists, can come from lab, can come from freestanding radiology centers, come from your doctor's office, emergency room, urgent care, telehealth. A lot of these types of providers are going to be generating that type of information on a CMS 1500. So if you decide, again, to move into healthcare, you just need to understand you'll need to buy you a little Sherlock Holmes type hat and put your thinking hat on, because you actually do become a detective when it comes to analyzing this type of information. If you don't decide to go into healthcare arena and go into the business intelligence world of, retail change, restaurants, manufacturing, pharmaceutical, a lot of other industries other than healthcare, a lot of the same concepts that we've gone over, maybe not so much down here in the clinical piece of it, but especially on some of the demographic information where you need to make sure you're capturing street address and telephone number and email address and especially zip code address and the bottom half of this invoice, because once you get away from healthcare, for the most part, you're working with invoices. On that invoice, you're going to have product numbers, you're going to have information based from the manufacturer, you're going to have pricing. You're just going to have a wealth of information in a non-healthcare environment. Maybe not the expansive access to information you have in healthcare, but you're still going to have a lot of information to sift through, and it's going to drive communications. It's going to drive reimbursement strategies. It's going to drive contracting strategies with suppliers. It's going to drive marketing information. So whether you go healthcare or whether you go some other market economy or some other industry, what you're seeing here, and as we try to tie all this together, it's interchangeable. It's all you have to do is before you go into interview, just get a little information about the industry and about the market and about the company you're going to interview for, and you'll be able to hit the ground running. You may have to learn some new computer software, but you should be able to hit the ground running, at least have an idea of what you're getting into. And with that, we're going to call it a wrap on this module. And when we get together next time, we're going to do a similar walkthrough with the UB04. Talk to everybody soon.